In our last video, we reviewed the workup and management of stable angina. That's all fine and dandy, but when acute coronary syndrome, or ACS, is the leading diagnosis, it's time to go into beast mode. In this sketch, we'll run through the assessment steps and immediate interventions needed to manage ST elevation myocardial infarction, non ST elevation myocardial infarction, and unstable angina. ACS is the umbrella term for these three syndromes, and it's sketchy, it's symbolized with a broken heartstring, though he doesn't seem too worried about it, but he should be. ACS is caused by the acute rupture of an atherosclerotic plaque and formation of a thrombus that impairs blood flow. Decreased coronary blood flow creates an oxygen supply and demand mismatch, leading to ischemia or infarction. At Sketchy, we represent the classic pain and pressure of angina with our recurring angina anvil. Unstable angina, therefore, is symbolized by an unstable anvil falling over. Unstable angina is caused by acute plaque rupture that results in cardiac ischemia without infarction. In patients with chronic stable angina, this can present as chest pain that increases in frequency, duration, or intensity from baseline, chest pain occurring at rest, or new onset severe chest pain. The ischemic symptoms can occur with or without ECG changes indicative of ischemia, which include ST segment depression, transient elevations, or new T wave inversions, which is why we've placed a fallen ST street sign next to the anvil. No persistent ST elevations to speak of. That was ischemia. How about infarction and cell death? The two categories of myocardial infarction are non-ST elevation MIs and ST elevation MIs. Non-ST elevation MI, or NSTEMI for short, is actually pretty indistinguishable from unstable angina from the start. Again, the patient presents with new onset ischemic chest pain, with or without ECG changes indicative of ischemia, which include ST segment depression, transient elevations, or new T wave inversions. So we've placed that fallen ST street sign next to this heartbroken NSTEMI minstrel. This time, however, ischemia results in infarction and myocardial cell death, which is measured as an elevation in cardiac biomarkers in the serum. Troponins, as usual, are represented by that troponin T-bone steak sitting beside their tip bucket. And finally, ST elevation MI, or STEMI, typically indicates complete transmural infarction, characterized by ischemic pain, persistent ST elevations, and cardiac biomarkers in the serum. Alright, before we get to the specific steps of ACS management, I want to briefly remind you of the signs and symptoms of ischemic chest pain that increase the likelihood of ACS versus stable angina or some other non-cardiac etiology. As we illustrated at the ischemic stables, ischemic chest pain is usually described as diffuse or difficult to localize, hence the diffuse black stains on the blacksmith's chest. It is more likely to be ACS if there is radiation to an upper extremity, even more so if it radiates to both arms. ACS angina is often associated with diaphoresis, nausea, and or vomiting, as experienced by the noob blacksmith apprentice down there. Stable angina is usually shorter, lasting 2 to 5 minutes, while ACS angina lasts longer than 20 minutes. That's why in the last sketch, 30 minutes of the blacksmith's clock was shaded red. Additionally, unlike stable angina, ACS can be associated with rest and may not improve with nitroglycerin. That's a good sign that you should start running down your ACS protocol. Of course, there are always those patients who just gotta be different and present with so-called atypical symptoms. These are things like shortness of breath alone, palpitations, syncope, or weakness. Atypical symptoms of ACS are more likely to be seen in older, diabetic, and female patients. Also, always ask a patient about previous MI and if this pain is like the last time he or she had a heart attack. ACS is a medical emergency and we need to act quickly. Time is muscle, baby. That's why the evaluation and management of the patient occur simultaneously. In these patients, start with your ABCs: airway, breathing, and circulation. To assess circulation, we measure the blood pressure and check peripheral pulses. If they are unresponsive, check for a pulse. If they do not have a pulse, start your chest compressions and treat according to the ACLS protocol. If they are in respiratory distress, you may need to put the patient on BiPAP or get ready to intubate. After your ABCs, screw D through H and go straight to IV, O2, and monitor. It's important to have IV access ASAP in all patients. These patients may need fluids to maintain blood pressure and perfusion, and IV nitro or beta blockers may need to be started urgently. Provide supplemental oxygen with a goal of maintaining O2 saturation over 90%. Notice how the reins on the king's horse look like oxygen tubing, and his glowing red scepter kinda looks like a pulse ox glowing on a finger. Am I right? For all patients, even those who are hemodynamically stable, make sure they're on a cardiac monitor and continuous pulse oximeter. And this guard holding the cardiac monitor flag is keeping a lookout, looking for any dynamic changes or arrhythmias. New arrhythmias such as atrial fibrillation, ventricular tachycardias, or AV blockade can be seen in ACS. For sustained ventricular arrhythmias, treat based on the ACLS protocol. To remind you of the potential for the onset of fatal ventricular arrhythmias, the King's Guard has brought along a recurring VTAC attack dog, complete with those jagged teeth, reminiscent of a VTAC ECG tracing. Call in the crash cart and go down your ACLS protocol, or in this case, bread cart. I mean, this is like the year 1490, so that'll do, I guess. A 12 lead ECG should be done within 10 minutes of arrival because rapid interpretation of the ECG is essential to properly triage your patient. On the ECG, we're looking for signs of cardiac ischemia or infarction. These include ST depressions or elevations, T wave inversions, peaked T waves, and Q waves. Check out our upcoming ischemia ECG video to review how to localize anatomically where the ischemia or infarction is occurring. To make a long story short, if you see ST elevation of 1 or more millimeters in 2 or more contiguous leads, just remember these two contiguous first street signs. Or an ST elevation of 2 or more millimeters in V2 and V3 specifically, then this is considered a STEMI. Additionally, a new left bundle branch block is concerning for myocardial ischemia or infarction and is treated as if the patient has a STEMI, so we've brought in the obligatory peasant dude with a bundle tied on his back. Unstable angina and NSTEMI, remember, look pretty similar on ECG. In fact, they are frequently indistinguishable until cardiac biomarkers are assessed. We'll get to tropes in a moment. For now, assess the ECG for changes indicative of ischemia, including ST segment depression or transient ST elevation and new T wave inversions. ST segment and T wave changes are often persistent in NSTEMI, while changes are usually transient in the setting of unstable angina. Keep in mind, however, that in both scenarios, the ECG can look normal. Yep, in the setting of ACS, that initial ECG is often non-diagnostic. So repeat the ECG every 10 to 15 minutes if suspicion for ACS remains high. For all suspected ACS patients, the patient should chew and swallow 325 milligram aspirin so it is absorbed into the bloodstream immediately. At Sketchy, aspirin is always symbolized by our aspirin umpire, with ASA emblazoned on his uniform. In this sketch, he's a horse handler. Let the carrot remind you that aspirin is chewed. And this ain't no baby aspirin. Hence the 325 incorporated into the horse mask. Remember that aspirin irreversibly inhibits COX-1 and 2. Inhibiting COX-1 prevents the production of thromboxane A2, which prevents platelets from sticking to the thrombus and worsening the blockage. Be aware that some patients will receive this in the ambulance on the way to the ER. In the hospital, you are working with a team. Teamwork makes the ACS protocol work. So while the nurses are doing some of the steps we just mentioned, you can obtain a focused history and examine the patient. Which is why we brought in the historian, a vital member of any royal cavalcade. By focused, I mean that you should key in on the important aspects of the chest pain to help rule in or rule out ACS. Now is not the time to get into a detailed sexual history, even if the unstable angina was in fact precipitated during sex. Just save it for later. Get their age. Then start with the HPI with a confirmation of the presenting symptoms. Have the patient characterize his or her pain in detail. Use OPQRST if that helps you remember all the important questions to ask, and remember all the features we outlined at the beginning of the sketch that point toward ACS as the likely cause of chest pain. And make sure to assess for any associated symptoms. Ischemic chest pain is also associated with nausea, vomiting, diaphoresis, dizziness, shortness of breath, and fatigue. Hit up our chest pain DDX video for a more in-depth look of all the other causes of chest pain that can sometimes mimic ACS. Let's give him a coronary crown clogged with gold as a reminder to assess for risk factors for coronary artery disease. Risk factors include a history of high blood pressure, high cholesterol, diabetes, smoking, and family history of MI. They may have history of other vascular diseases or events as well, including peripheral artery disease or stroke. And of course, don't forget to ask if the patient already has a history of CAD or prior MI. If so, ask them if this feels like their last MI. Now is also a good time to ask about recent cocaine use. As we highlighted in our chest pain video, cocaine can precipitate coronary vasospasm and ACS. You'll also want to assess for potential contraindications to thrombolytic therapy, in case your patient is headed toward thrombolysis instead of PCI. Absolute contraindications to thrombolytic therapy include anything that could increase the risk of the patient hemorrhaging, especially intracranially, hence the hemorrhage of ink we've got going on over here. For example, a history of prior intracranial hemorrhage, known AV malformations, intracranial neoplasms, or in the last 3 months have had an ischemic stroke or head trauma. Not surprisingly, patients with suspected aortic dissection, active bleeding, or bleeding diathesis should also not receive thrombolytic therapy. Also be sure to review medications the patient is taking. Especially ask about recent phosphodiesterase 5 inhibitor use like sildenafil because you cannot give nitrates to these patients due to the risk of hypotension. Alright, let's get physical. Moving on to the physical exam. This includes a focused cardiac and pulmonary exam. Even before you put your stethoscope on the patient's chest, how do they appear in general? Patients with active chest pain may be diaphoretic. On the cardiac exam, possible signs of myocardial ischemia or infarction include S3 or S4 heart sounds or a new mitral regurgitation murmur due to papillary muscle dysfunction. So we've brought in one of the townsfolk whistling a murmur as the cavalcade goes by. We've also added our recurring symbols for S3 and S4 heart sounds, the S3 slushy and the S4 chair. The slushy doubles as a reminder of what the S3 sounds like. It occurs when fluid enters the left ventricle and hits the residual fluid sitting in there that the ventricle had a hard time ejecting. You'll hear the fluid sloshing in, sloshing in, sloshing in, sloshing in, and the stiff S4 chair. Think of the fluid entering the ventricle hitting a stiff, immobile, infarcted myocardial wall. The gallops sound like a stiff wall, a stiff wall, a stiff wall. Although many patients with ACS may have normal vital signs, a large myocardial infarction can cause acute heart failure, leading to cardiogenic shock, as highlighted by our recurring shock lightning bolt symbol. These patients require aggressive management. Patients in cardiogenic shock are typically very ill appearing, with cool, pale, clammy skin. They may be lethargic or disoriented, and of course, hypotensive with compensatory tachycardia. Also, let our recurring floppy failing heart balloon remind you that it is important to assess for signs of heart failure, as these patients will also require aggressive treatment. Typical signs of left heart failure include hypotension, elevated jugular venous pressure, symbolized by those bulging jugular braids, by basilar crackles, symbolized by those bubbling wet lungs. And don't forget about that S3 kid over there, as the S3 heart sound is a classic sign of ventricular failure, a sign that blood entering the ventricle is hitting the leftover blood that wasn't ejected due to decreased ejection fraction. And I think now is a good time to bring up right ventricular involvement. In our upcoming ischemia ECG sketch, we'll elucidate the anatomical location of the myocardial infarction based on the pattern seen on the ECG. Well, judging by the fact that the inferior portion of this lady's dress is scuffed up and ischemic, I'd say she's an apt representation of inferior MI. Inferior MI involves an occlusion in the right coronary distribution and presents on ECG with ST elevations in leads 2, 3, and AVF. In about a third of patients with inferior MI, the right ventricle becomes infarcted, which typically presents with the triad of hypotension, clear lung fields, and elevated jugular venous distension, again symbolized by those distended blue braids. Yep, we've got clear lungs this time, people, as opposed to the wet lungs caused by the left-sided heart failure. Special care is taken to maintain right ventricular preload in these patients, which we'll get to in a moment. In the setting of hypotension, you'd expect tachycardia. However, some patients may be bradycardic, as symbolized by Alice up here with the dangling heart watch. This could also be a clue to an inferior myocardial infarction. An infarct on the inferior wall can irritate the diaphragm and the vagus nerve running nearby. Stimulation of the vagus increases vagal tone on the heart, leading to bradycardia and heart block. Blockage of the right coronary artery may also disrupt the blood supply to the SA node. And another thing, it's of utmost importance to perform a focused neuroexam in order to assess for deficits that might preclude the use of potential thrombolytic therapy. Yeah, you remember all those contraindications. It's also important to record the patient's baseline neurologic function, because if fibrinolytics are given, you must monitor for sudden neurologic deterioration from baseline, as this could indicate intracranial hemorrhage. And why the Vitruvian Man? Well, don't be too surprised. I mean, the late 1400s is the right time period. At Sketchy, this is our symbol for a normal physical exam. And it's here to remind you that there may be no abnormal findings on physical exam, but that does not exclude ACS. Time to get them labs. What were labs like in the 1400s? Well, I've heard that the search for the philosopher's stone is all the rage right now. But on top of turning base metals into gold, you'll probably want to order some basic blood work like CBC, BMP, and coags. And most important of all, cardiac biomarkers. The gold standard for diagnosing myocardial infarction is an elevated serum troponin. Troponin is very sensitive and specific and is detectable usually about 2 to 3 hours after symptom onset. Hence the 2-hour wait time at the troponin T-bone steak shop. Troponin typically peaks at about 12 hours but will remain elevated for 10 to 14 days. Another cardiac biomarker is CKMB, a type of creatine kinase protein that is found predominantly in the heart and is released in the setting of myocardial infarction. However, it is less specific and sensitive than troponin because it can also be released by damaged skeletal muscle. CKMB levels begin to rise 4 to 6 hours after infarction, but may not actually be elevated compared to the normal range until 12 hours. Levels return to baseline within 36 to 48 hours, much sooner than troponin levels. Therefore, if a patient who had a recent myocardial infarction, like in the last few days, develops recurrent chest pain, checking a CKMB level will technically be able to tell you if early reinfarction is occurring. In reality, however, troponin is still the most sensitive and specific measure of cardiac injury, even in the setting of reinfarction. In patients hospitalized for ACS, troponin levels and an ECG are checked again in 6-hour intervals to see if there are any signs of worsening ischemia or to monitor for improvement. You may hear this referred to as serial troponins and ECGs. These tests may be performed more frequently if the patient develops new or recurrent symptoms. As we outlined earlier, cardiac biomarkers are essential in the diagnosis of myocardial infarction. Combined with ECG, we can differentiate between the three categories of ACS: unstable angina, NSTEMI, and STEMI. In contrast to NSTEMIs and STEMIs, unstable angina does not feature elevated troponin or CKMB levels. The EKG, however, may or may not have ischemic changes. Meanwhile, NSTEMIs and STEMIs feature elevated cardiac biomarkers because, as the names imply, there is myocardial infarction leading to the release of troponin and CKMB into the blood. In a patient presenting with acute chest pain, you've got to work quickly to identify the cause. To that end, let's quickly review some of the can't miss diagnoses you should have on your differential. One disorder you definitely don't want to miss is esophageal rupture. This life threatening condition typically produces sudden onset of sharp chest pain. On exam, you might be able to palpate subcutaneous emphysema over the chest, indicative of free air in the mediastinum. You can see mediastinal free air on a chest x-ray as well. Another biggie is aortic dissection, which usually causes a sudden tearing chest pain radiating to the back. Look for a widened mediastinum on chest x-ray to confirm your worst fears. Of course, don't forget pulmonary embolism. PE typically causes pleuritic chest pain, dyspnea, and tachycardia. A history of recent DVT symptoms is pretty common as well, so make sure to ask about and look for leg pain, edema, and erythema. If you have some suspicion for a PE, your next step should be testing. A D-dimer can help you rule it out in patients with low pretest probability, while patients with greater likelihood should get a CTA to rule it in. Similar to PE, pneumothorax can also cause sudden onset of pleuritic chest pain. However, listen for the absence of breath sounds and percuss for increased resonance on the affected side to clue you into the diagnosis. Finally, clinically significant pneumothorax is pretty apparent on a routine chest x-ray. Continuing on our list of life threatening conditions on the differential for ACS, let's talk about cardiac tamponade. Look for the characteristic Beck's triad: hypotension, elevated JVP, and muffled heart sounds on exam. But be aware that you won't see it in many patients presenting with tamponade. On ECG, diffuse low voltages and electrical alternans are the unique features that'll help you distinguish cardiac tamponade from acute coronary syndrome, so look closely. Finally, let's briefly mention the classic mimicker of ACS type chest pain, vasospastic angina, also known as Prinzmetal angina. Since vasospastic angina occurs due to, well, coronary vasospasm and not coronary atherosclerosis, expect patients who present with it to be different from your typical ACS patient. Specifically, younger age and angina occurring at night, that is, at rest, can help distinguish vasospastic angina from ACS. For more details on these and other conditions on the differential for chest pain, head back to our first sketch in this chapter. All right, how about a sample assessment statement? Mr. Stemley is a 58-year-old male with hypertension who presents with chest pain. Chest pain is located on his left side, described as pressure-like, and is associated with shortness of breath and nausea. His symptoms started 6 hours ago while he was working in the yard. Vital signs and physical examination are normal. EKG shows ST elevations greater than 1 millimeter in the anterolateral leads, troponin T is elevated, and the chest x-ray is unremarkable. This is consistent with a STEMI. Components of the initial management of ACS can be remembered with the mnemonic MONA-Bs, which stands for morphine, oxygen, nitrates, aspirin, beta blocker, and statin. However, in real life, we actually follow a different order. Recall, patients are started on oxygen early on in the assessment if their oxygen saturation is less than 90%. We also give patients chewed aspirin immediately in the case of suspected ACS. In fact, they may have already received this in the ambulance. For ongoing chest discomfort and hypertension, a short-acting nitrate is typically administered at a sublingual dose of 0.4 milligrams every 5 minutes for a total of 3 doses. This is highlighted by the sublingual theme door knocker next to the 5-minute sign, and the knock 3 times sign to remind you of 3 sublingual doses total. If the need for blood pressure control or pain relief persists, IV nitroglycerin can be administered. So let's add some IV on the side here, next to this sad, persistently symptomatic minstrel. Recall that nitrates cause both arterial and venous dilation. The venous dilation helps decrease preload, while the arterial dilation decreases afterload. Ultimately, this decreases the load on the heart and reduces myocardial oxygen demand. Nitrates also vasodilate the coronary arteries, improving oxygen delivery to the heart. Whoa! Keep in mind the important contraindications to nitrate therapy as highlighted by the signs above the nitro shop. That fainting guy should remind you to not use nitro in patients who are already hypotensive. Also, nitro should be avoided in patients with right ventricular MI. Patients with right ventricular failure need all the preload they can get. Venous dilation and reduced venous return is not going to help. On top of that, one more contraindication to keep in mind. That do not overfill bucket is here to remind you that nitro is contraindicated in patients who have recently used a phosphodiesterase 5 inhibitor like sildenafil, tadalafil, or vardenafil. These medications are used to treat erectile dysfunction as well as pulmonary hypertension, but their combined effects with nitro can precipitate severe hypotension. The B of MONA-B is beta blockers. At Sketchy, beta adrenergic activation of heart rate and contractility is symbolized by a rousing beta bugle. To represent beta blockers, therefore, we use a muted beta bugle. Beta blockers like metoprolol tartrate are used to reduce myocardial contractility and minimize tachycardia, thereby lowering the oxygen demand of the heart. This, plus other potential beneficial effects, help to reduce infarct size and early mortality. Patients should receive a beta blocker within the first 24 hours of diagnosis of ACS. Watch out though. Beta blockers are contraindicated in patients with bradycardia, signs of heart failure, or signs of hemodynamic compromise. Hence the caution sign behind this bugler carrying our symbols for heart failure and bradycardia. And why is he choking? It's a reminder that patients may have an allergy to beta blockers, or beta blockers may precipitate bronchospasm in some patients with underlying reactive airway disease. If this is a concern, a non dihydropyridine calcium channel blocker can be used instead. Next, the M in Mona B. In some patients, you might consider giving morphine. Morphine decreases anxiety and pain, which reduces sympathetic activation of the heart and therefore lowers myocardial oxygen demand. However, because morphine can cause a drop in blood pressure, the warning signs up here apply to morphine as well. Do not give morphine to patients in cardiogenic shock or those with a right sided myocardial infarction, as it can lower their preload and worsen cardiac ischemia. Morphine should only be used if chest pain is unable to be adequately controlled with nitrates, as its use has been associated with poorer outcomes. And finally, check out that intense S explosion at the end of Mona B's. That's S for high intensity statins. As soon as the diagnosis of ACS is made, give a high intensity statin like 80 milligrams of atorvastatin. Before getting into the definitive treatment of MI, let's cover a few scenarios that require extra intervention. In patients with cardiogenic shock and severe hypotension, pressors can be administered in an attempt to preserve venous return, blood pressure, and organ perfusion. Norepinephrine is often the pressor of choice. Patients with signs of left heart failure, such as pulmonary edema, should be treated immediately with nitrates and an IV loop diuretic. Nitrates, such as nitroglycerin, reduce preload through venodilation and afterload through arterial vasodilation. This helps us unload the left ventricle, which improves left ventricular stroke volume and helps us clear out those lungs. IV loop diuretics, such as furosemide, are used for diuresis. By reducing intravascular volume, diuresis helps lower central venous pressure as well as capillary hydrostatic pressure. Less hydrostatic pressure means less edema. But before the diuresis sets in, furosemide has an immediate vasodilation effect, which helps reduce pulmonary congestion in the setting of acute pulmonary edema. Check out our decompensated heart failure video for all the wet deets. Yet again, you've got to keep those warning signs in mind, I'm afraid. Nitro and diuretics are avoided in the setting of right ventricular infarction, in which case preload to the heart is of utmost importance. These interventions are also avoided in the setting of cardiogenic shock, when last thing we want to do is further decrease blood pressure. And while I've got you thinking of right ventricular infarction, let's add some extra interventions. Right ventricular infarction, remember, classically presents as an inferior MI with clear lung fields and shock. And, as this sketch has continuously emphasized, it is extremely important to maintain venous return so we can fill that failing right ventricle and maximize flow to that left ventricle, thus preserving cardiac output. In patients with hypotension due to right ventricular infarction, this can be accomplished by administering IV fluids. Also, notice that her jugular braids are nice and, well, not dilated. IV fluids are indicated during an RV infarct only if the jugular venous pressure isn't elevated. In patients with elevated JVP from heart failure, the right side of the heart is already filled to the max. Adding more fluid will only lead to excessive distension of the right ventricle. which impairs left ventricular filling and destroys your cardiac output. And I know this whole time you've been wondering how Alice fits into the equation. Alice is our recurring sketchy symbol for atropine. Sinus bradycardia can follow an acute MI, especially an inferior MI. If bradycardia is persistent and is causing hemodynamic compromise, atropine can be administered to bump up that heart rate. Let's move on from the complications and get to the definitive treatment of a patient diagnosed with STEMI, NSTEMI, or unstable angina. Let's start with STEMI. The focus for STEMI management is immediate reperfusion, illustrated here next to the elevated ST sign. Early reperfusion in STEMI improves mortality. Coronary angiography should be performed immediately in patients with ST elevation, myocardial infarction, with a door to balloon time of less than 90 minutes. This means the moment this patient gets into the ED to the time they are on the cath table should be within 90 minutes, emphasized here by the 90 shape of the balloons. This dude's hat looks pretty funky as well. It's supposed to evoke an image of contrast in the coronary arteries. Coronary angiography is used to identify a stenosed artery or arteries. Percutaneous coronary intervention, or PCI, is then performed in order to open up the vessel and restore blood flow. PCI consists of opening up the stenosed portion with a balloon, followed by placement of a stent to hold it open. Coronary artery stents come in two flavors, bare metal and drug-eluting, represented here by those two sleeves which resemble cardiac stents. One of them, as you can see, looks like it's made of bare metal, while the other is eluting some trickery for unsuspecting passers-by. Typical minstrel antics. An important difference between bare metal and drug-eluting stents is the duration that patients will need to be on dual antiplatelet therapy afterwards. We'll discuss this in our next video where we talk about discharge medications. Note that we do not always place a stent. Sometimes a patient may need a full-on coronary artery bypass graft surgery, or CABG for short. This would be recommended for patients with stenosis of the left main coronary artery or severe multivessel coronary disease. And if you take a look at the CABG chart, you'll see that we've highlighted a left root blockage as well as a multi-root blockage. Of course, there are many nuances in the decision to perform PCI versus CABG, but those are just some basic principles. Before PCI was commonly available, blood flow was restored with thrombolytic therapy, with a tissue plasminogen activator drug. Thrombolytic therapy is also known as fibrinolytic therapy and is represented here by this kid disrupting this pile of thrombotic hay. The most commonly used drug for acute myocardial infarction in the United States is tenecteplase. PCI is superior to thrombolysis, and for that reason, if patients present to a hospital that does not offer PCI, it is recommended they be transferred to another hospital if they can have PCI within 120 minutes of first medical contact. That P sign indicates 2, as in 2 hours. If that is not possible, then thrombolytic therapy is administered, assuming there are no contraindications. Yeah, you remember those, right? Absolute contraindications to thrombolytic therapy include anything that could increase the risk of the patient hemorrhaging, especially intracranially. This includes a history of prior intracranial hemorrhage, known AV malformations, intracranial neoplasms, or in the last 3 months have had an ischemic stroke or head trauma. Not surprisingly, patients with suspected aortic dissection, active bleeding, or bleeding diathesis should not receive thrombolytic therapy. So, once you've decided on PCI versus thrombolysis, you'll give both antiplatelet and anticoagulant medications to your STEMI patient. Let's start off with our antiplatelet medications, symbolized underneath that Armored Plate Company sign. That's Armored Plate for antiplatelet. We already mentioned earlier that all patients with suspected ACS get aspirin. In addition to aspirin, patients are treated with a P2Y12 ADP receptor blocker such as clopidogrel, ticagrelor, and prasugrel. This double whammy on platelet aggregation is known as dual antiplatelet therapy. We've placed a take a prize box next to our stented friend over here to remind you that ticagrelor and prasugrel are preferred agents for STEMI patients undergoing PCI due to decreased mortality from stroke and MI. That's take for ticagrelor and prize for prasugrel. On the other hand, patients who are unable to get PCI and get thrombolysis instead are treated with clopidogrel, symbolized by the horse Klops going by. Clopidogrel is preferred simply because the other agents haven't been studied in conjunction with thrombolytic therapy. Now that the patient's platelets are inhibited, the next step is therapeutic anticoagulation. So, if armored plate was antiplatelet, armored co is anticoagulation. Anticoagulation inhibits thrombus propagation, which prevents worsening ischemia and infarction. Unfractionated heparin is the agent most commonly used. Remember that unfractionated heparin is given as a continuous infusion and has a short half-life. This makes it the preferred anticoagulation agent in patients who will be undergoing PCI, as it can quickly be turned off. Other options include bivalirudin, a direct thrombin inhibitor, which can be used in patients with a history of HIT. If no PCI is planned, patients may receive fondaparinux, a selective factor Xa inhibitor, or enoxaparin, a type of low molecular weight heparin, which have longer half-lives. Now that you're solid on STEMI management, we'll move on to NSTEMI and unstable angina. Luckily, there's a fair amount of overlap, as you'll see. Just as we saw with STEMIs, unstable angina or NSTEMI patients are treated with dual antiplatelet therapy. So we've drawn in another armored plate sign. Dual antiplatelet therapy includes aspirin and a P2Y12 ADP receptor blocker such as ticagrelor, prasugrel, or clopidogrel. Patients should also receive anticoagulation therapy, hence the armored co part of the sign. Similar to STEMI patients, if there is a plan for an invasive procedure, unfractionated heparin is typically the drug of choice. Meanwhile, if there is no plan for an invasive procedure, then you might use enoxaparin or fondaparinux instead. With unstable angina and NSTEMI, the major options here are immediate angiography for the highest risk patients, angiography within 24 to 48 hours for intermediate to high risk patients, or conservative therapy for low risk patients. The TIMI and GRACE risk scores are two tools to help us determine which path to choose, embodied by little orphan Timmy here at GRACE Orphanage. These scores help us assess the patient's risk of complications, such as recurrent MI, recurrent angina requiring revascularization, and death. Higher risk patients will undergo an interventional cardiac procedure, and low risk patients will be treated conservatively. Note that, unlike STEMI, thrombolytic therapy is not an option in the case of NSTEMI or UA, as prospective trials have not shown a benefit in these patients. So let's start off with immediate angiography. This is for patients who are at high risk for poor outcomes. Specifically, those who are hemodynamically unstable, have overt heart failure or severe left heart failure, ongoing or recurrent rest angina, acute mitral regurgitation or ventricular septal defect, sustained VTAC, or dynamic ST T-wave changes. Generally, if they have really bad stuff going on, these patients will undergo coronary angiography and PCI with stent placement if indicated. Just take the balloon, kid. For patients who are more stable than the above patients, but still considered intermediate to high risk based on our risk scores, we perform coronary angiography within the first 24 to 48 hours. Features that increase the patient's risk of complications include abnormal vital signs, evidence of heart failure, older age, elevated cardiac biomarkers, EKG abnormalities, history of CVD risk factors, or CAD. These are taken into account with the TIMI and GRACE risk scores. Lastly, patients deemed to be a low risk for death or recurrent MI will usually undergo stress testing instead, kind of like the stress test being performed right now by this orphan powering the drawbridge. If there are high risk findings on stress test, then patients will undergo coronary angiography. Keep it moving, Timmy. 1490s. What a time to be alive, eh? Prithee, listen as I recount the tale of ACS management. Ye should consider ACS in patients with chest discomfort, shortness of breath, or other signs and symptoms of cardiac ischemia. Remember that some patients have atypical presentations. First things first, ABCs. Establish IV access. Attach the cardiac and O2 monitors and deliver oxygen to keep the O2 sat above 90. Treat ventricular arrhythmias according to the ACLS protocol. Get a 12-lead ECG within 10 minutes. Repeat every 10 to 15 minutes if non-diagnostic. Give aspirin, 325 milligrams, chewed. Get a focused history, including HPI, past medical history related to CAD, recent cocaine use, and contraindications to thrombolytic therapy. Ask about medications too, including PDE5 inhibitors. Perform a focused physical exam. Look for signs of shock and consider pressors. Look for signs of left heart failure, including pulmonary edema. Treat with nitrates and an IV loop diuretic. Nitrates and diuretics are avoided in right ventricular infarction and hypotension. And speaking of, look for signs of right ventricular infarction, including inferior MI, clear lungs, and shock. Treat with fluids to maintain preload, unless they have JVD, which means the heart is already overloaded. Inferior MI can cause bradycardia. If they're symptomatic, consider atropine. Order CBC, BMP, and coags. Get cardiac biomarkers. Repeat troponins and ECG every 6 hours. For persistent chest pain, hypertension, or heart failure, give sublingual nitroglycerin. 3 doses, 5 minutes apart. Add IV nitro for persistent symptoms. Again, remember, nitro is contraindicated in right ventricular infarction, hypotension, or recent PDE5 inhibitor use. Start a beta blocker, typically metoprolol tartrate, unless there are signs of heart failure, shock, bradycardia, or reactive airway disease. As for the rest of MONA-Bs, consider giving morphine for severe pain and start a high-intensity statin. In the setting of STEMI, perform coronary angiography within 90 minutes of presentation. Start dual antiplatelet therapy and anticoagulation. For unstable angina and NSTEMI, pursue immediate angiography and PCI in unstable patients. Intermediate to high-risk patients should undergo angiography within 24 to 48 hours. Low-risk patients should undergo stress testing prior to discharge. I said keep it moving, Timmy.
Sorry, my lord.
Kids these days.